Welcome back to the Diet Doctor podcast. I'm your host, Dr. Brett Scher. Today I'm joined by Dr. Anna Lorenzo. Now, as you'll hear us discuss, Anna's a little unlike any other doctors we've had on this podcast. She's an ophthalmologist. And what's interesting is this metabolic disease we talk so much about, whether it's insulin resistance, type 2 diabetes, so much of the focus is on the heart, the kidneys, the blood vessels, the sort of the overall metabolic condition. But it also affects the eyes, and it can affect it quite severely. So as we're going to hear, Dr. Lorenzo specializes in what's called anterior segment surgery or cataracts. And people with type 2 diabetes are more likely to get cataracts. But when she looks into someone's eyes and can examine and see the back of their eyes, she can already see changes from diabetes called diabetic retinopathy. And through her own personal experience and her family experience, she came across low-carb lifestyles as a way to dramatically improve and treat blood sugar control for people with type 2 diabetes. And now she's able to apply that to her patients who she sees for eye problems, but then can make the diagnosis of type 2 diabetes or can help treat their type 2 diabetes with low-carb lifestyle. So it's a wonderful example of, the old saying of stay in your lane. Well, she didn't stay in her lane, and thank goodness, because she's helping so many people. You might say, eye doctors just need to stay in their lane and treat the eyes, but no. She took it into her own hands to help her family and now is using that to help her patients. And I think it's a wonderful example. And you can see she's a very kind and caring person. So she definitely wants to help people. And this is a great way that she can do it. So I hope you enjoy this interview with Dr. Anna Lorenzo. Well, Dr. Anna Lorenzo, thank you so much for joining me on the Diet Doctor podcast.
Oh, thank you, Dr. Brett. I'm very happy to be here. For me, it's an honor. You are one of my long-distance teachers, so I'm so excited. And Diet Doctor, it's been a great tool for me and my patients, so I can be happier. Thank you so much.
Thank you for that. I appreciate it. Well, we've had quite a few doctors on the Diet Doctor podcast, but most of them deal with sort of the internals of the body, the metabolism, the heart, the kidneys, the endocrine system. But now you are an eye specialist. And I'm sure a lot of people are thinking, well, what does the eye have to do with glucose and insulin metabolism and overall health? But interestingly, it does. And I definitely want to get into that. But first, tell us a little bit about your background and how you got into being an ophthalmologist and specifically a cataract specialist.
Sure. Well, I studied medicine in the Anáhuac University. It's a very prestigious university here in Mexico City. And I liked all specialties. I wanted to be a cardiologist, a neurologist, an internal medicine doctor. But at the end, I decided I want to do a surgical specialty. So I wanted to make a difference in the world. So I just thought that ophthalmology would be a high impact specialty because, the site is valuable for a lot of patients. So, and also for the lifestyle that I wanted to be able to manage my own time. So that's why I entered ophthalmology, among other reasons.
Yeah, that's a good description. It's important to feel like you are really making impact and seeing that impact. And with ophthalmology, you certainly can see that. I mean, people walk out of your operating room completely different in terms of their ability to see, and that's pretty remarkable. But one of the things I always really just sort of took in with awe and was amazed about is how much you could learn by looking into somebody's eyes. And it's one of the hardest physical exams to get used to. Putting a stethoscope on someone's chest to listen to their heart is pretty easy. But taking the special magnifier, looking into someone's eyes, getting real close and actually seeing the back of the eye can tell you so much about a person's overall health. So the eye is the window to the soul. Well, the eye is also sort of the window to the health. So tell us about some of the things you can learn just by looking into somebody's eyes.
Yeah, actually, well, at least here in Mexico, you don't get to know a lot about ophthalmology until you enter the residency. Because it's very different to look through the direct ophthalmoscope than to look at it from the slit lamp. It's very different. You can see a lot of things, a lot of signs. For example, a lot of people don't even know that they are diabetic and I find out some signs into their eyes, into when I do the retinal exam with a dilated pupil, and then I can see microaneurysms or hemorrhage or stuff. And I tell them, "Oh, are you a diabetic?" And they didn't even know that they had diabetes or hypertension or some other problems that you can directly see into their retinas. So, yeah, we tend to have a lot of patients with undiagnosed diabetes that through our medical exam, we can diagnose them.
Yeah, so that's pretty remarkable that they walk into your office because of an eye problem, but then you can make the diagnosis of this systemic metabolic disease of type 2 diabetes or hypertension or metabolic syndrome that they had no idea they even had. I mean, that's a pretty powerful diagnostic tool. No blood tests needed, no special scans needed, just looking in the back of somebody's eye. So you mentioned some fancy terms there, but basically, I guess if you were to simplify what those terms means, it's an abnormality of the blood vessels in the back of the eye, which can then affect the retina itself and the vision itself. Is that a sort of an accurate way of saying it?
Yes, the problem with diabetes is that it affects the small vessels in the retina. Sometimes they can dilate and form microaneurysms. And these blood vessels, they are tiny blood vessels, they can leak, and they can cause macular edema. That means that that they start leaking, and there's like an accumulation of fluid between the layers of the retina. And but on the other side, they can close up, and then you have macular ischemia because the blood can't reach the retina, the layers of the retina, and then you have ischemia. So it can go both ways, but you can see the changes, the early changes. Even if the patient has a vision of 20/20, you can look at these signs and know that they have some sort of disease.
So that's interesting. So there could be zero vision changes. Their vision is perfect as far as they can tell. But they could be having already manifestations of this. So if they were to develop symptoms of diabetic retinopathy or the eye disease from diabetes, what type of symptoms would they start to present with?
Yeah, at the beginning, most patients are asymptomatic. They don't see any changes. That's why it's very important for patients to check their eyes at least once a year, even if you think you are healthy. That's but here in Mexico, at least, people don't go to preventive medicine. They only go to the doctor when they have some symptoms. They can see very well, or they want to change their glasses prescription. So that's not very good. Or maybe they come, but when they start having this uh, vision loss, and maybe the diabetic retinopathy, it's already advanced, and there's not so much that we can do about it, or it's harder to treat. So it's advisable for all patients, even if they think that they are healthy, or even if they think that they have very good eyesight, to check their eyes at least once a year, because there are silent diseases like diabetic retinopathy, but there are others like glaucoma. So it's advisable that people check their eyesight once a year.
Yeah. Well, that certainly makes sense. And then if they have symptoms of floaters, like little
Yeah.
dark spots floating across their vision or black spots where they sort of can't see through part of their vision, obviously that's sort of a red flag that they need to get their eyes checked right away as well.
Yeah,
Right.
and a very early sign of, for example, diabetes is that they can have changes in their eyesight even in the same day. For example, they say, "Oh, in the morning, my eyesight is it's better, but in the afternoon, evening, it's getting worse," and then come back again. So that's an early sign, and that means that their glucose levels it's changing. And that's a very early sign. It's important, for example, to know if your glucose level is high, you can't get a prescription for glasses because it's not going to help you. It's going to change, and then when your glucose levels goes down again, then your glasses prescription is going to change again.
Oh,
So
wow.
it's important to have like a stable blood glucose before you have a prescription. And that's because the crystalline lens, it gets swollen. and then your prescription or your eyesight changes a lot. So that's a very early sign, and that's when you start suspecting that something is off. When people tell you that their vision is changing a lot during the same day, or in maybe a day or two, it's changing a lot, then that's like a red flag for me.
Okay. Interesting. Now I'm sure you see a high percentage of patients with diabetes because type 2 diabetes is also a precursor to developing cataracts, which is your specialty. But that's something you can sort of treat. You can remove the diseased lens and put a new lens in, and basically they're good to go. You've sort of fixed their cataracts. Is the same true for diabetic retinopathy? Is that something you can fix or reverse, or is that something you just sort of have to try and manage with surgery?
Well, it depends on what stage of the diabetic retinopathy it's the patient. For example, it's very early or it's very recent, the macular edema, then it's completely reversible. And this is the early stages when they can have a perfect vision. So it's important to check them and to manage their diabetes. But for example, if it's chronic macular edema, that means that more than 3 months, then it's harder to reverse it. Or, there's basically two different stages. One is non-proliferative diabetic retinopathy, and that usually it's reversible or at least manageable. But when this progresses to proliferative diabetic retinopathy, then it's harder to treat, and also sometimes it's non-reversible. The difference is that when you have a proliferative diabetic retinopathy, there are new blood vessels that form, but these new blood vessels are really thin, and they break, and then you have a vitreous hemorrhage or hemorrhage in between the layers of the retina, and then it progresses, and you can have retinal detachment or other irreversible consequences. So it's very
Yeah.
important to check them in early stages so that it can be reversed. For example, if it's macular edema, it's reversible, but only when it's not chronic.
Right. And now I'm sure when you went through your ophthalmology training, you learned all about the photocoagulation and the vitrectomy and the different surgical approaches to addressing diabetic retinopathy. But did you learn anything about treating diabetes and trying to manage diabetes, either with lifestyle potentially to help reverse or stop the progression of diabetic retinopathy?
Not at all.
Yeah.
Yeah, I learned that as in medical school, we learned that diabetes is a chronic condition that's non-reversible, progressive, and that basically it's a life sentence. So they teach you also. Well, I learned at residency that the only thing you could do is to have a close follow-up of patients, so that you manage their symptoms with either photocoagulation, that's laser, or with anti-angiogenic drugs, that's injections into their eyes. But unfortunately, for example, these injections for macular edema or to prevent, trying to prevent the proliferation of new blood vessels, that only lasts for about a month. So patients have to come back, have those injections every month. So that's not a very good quality of life. So that's what I learned, and that you can only manage the complications as they present. But
Yeah.
now
Well,
I
but
know better.
now you know better. Exactly. Now you know better. So now you've been a vocal supporter of using lifestyle, specifically nutrition and specifically low carb lifestyle to help treat the underlying diabetes and thereby also treating the diabetic retinopathy. So before we get into sort of the specifics of how that works, tell us about your personal journey and how you came to learn about low carb lifestyles and the effects they can have for health, because like we said, you didn't learn it in your medical training. So how'd you learn it?
Yeah, my journey started about 5 years ago, and it all started because of my dad. I remember it was New Year's Eve. I was at the beach with my now husband, and my sisters called me worried about my dad because he had been losing weight and he had a bad flu. I think he lost around 10 kilos. That's about 20 pounds in about 15 days. And he wasn't getting any better from a flu he had. So the first thing we thought it was that he had cancer. And I ordered some blood work, and it was a surprise to know that his blood glucose was in around 300 milligrams per deciliter. That's about 18 millimoles per liter.
Very high.
Yeah, very high. So he was diagnosed with diabetes. So he was referred to an endocrinologist, and he started as every other diabetic patient with medications and with low fat and high carb, whole grains, and orange juice for breakfast, and all this crazy diet and crazy treatment. So at the beginning, the endocrinologist managed his blood glucose, but he started feeling not so well. For example, he loves to take long walks in the park, but 2 times he just lost consciousness because he had hypoglycemia. So they called my mom, and it was really bad. So I talked to his endocrinologist and asked him to lower his medication. But he was reluctant to do so because he thought that his glucose was well managed while he didn't exercise. So just tell him to not exercise, and he was like really sad. So I was disappointed and start doing my own research because I knew what that path could be as a doctor. I knew that he would only be put on more medications and then insulin and then 3 types of insulin, and maybe he would go blind or started with nephropathy. So I just started doing my own research. And that's why I came across the low carb world and the ketogenic diet and Diet Doctor and Dr. Jason Fung. And everything changed for me. I started questioning everything I've learned about nutrition and the way we treat diseases, and to ask ourselves if it's the best way or the best treatment for, especially for diabetes. So I talked to my dad about all that I was learning, but first I started doing myself the ketogenic diet because I wasn't going to put my dad or any other patient through something that I wasn't went through. So I did it myself, and for me it was amazing because I lost like 5 kilos, like 10 pounds in about 2 weeks. I didn't have like a lot weight to lose, but I started feeling amazing. My focus, my energy, even my exercise performance, everything was better. I was feeling so great. So I start talking to my dad about this new treatment I just discovered. But at the beginning, he didn't want to do the. He didn't was sure about this new way of eating because it directly was exactly the opposite that the endocrinologist was prescribing him. So I reached out to Dr. Jason Funk, and I went to Toronto to do a clinical rotation. And that's where also when my life changed because I learned how diabetes was reversible. But I knew a lot of patients who could reverse their 20 plus years diabetes. They were on high doses of insulin, and it all was reversible. So I came back, and within 1 month, my dad lost. Well, he just went off medication, and his blood glucose was at normal levels.
I'm dying to know, how did his doctor react to that? The doctor who said you just can't exercise and stay on your high doses of medication. So how did he react when your father responded so well to a low carb diet?
Yeah, he didn't respond very well. He was actually mad at me because he thought that I was hurting my own father. So, but my dad saw the results. He just has he had a lot of gastrointestinal upset, And he just, when he stopped taking the medications, everything changed for him. I was very closely monitoring him. I called him every day, and one day I called him and, Dad, how are you doing? Oh, I'm great. I have to call you back because I'm at the gym now, so I'll have to call you back. So he went back to exercise. I mean, his whole life changed. So
Yeah, that's
yeah, it was.
remarkable.
Yeah, and he definitely stopped seeing that doctor because he didn't want, he thought that he was going to hurt himself, and he didn't want to get involved in his
Yeah,
treatment. So
it's such an interesting way to how to think about a doctor like that, because it's not like the doctor was trying to hurt your dad. It's not like the doctor was trying to be mean or controlling necessarily, but just that's the way the doctor was taught. And let's face it, as physicians, we're not really taught to question guidelines. We're not taught to question authority, which is a big problem, I think, in medical education. So anything outside of what the guidelines say was completely foreign and a threat. And so on the one hand, you can sort of understand why the doctor would react that way, but when he just comes down to common sense and hearing stories like this, it's like, how could anybody react that way? Like, we really need to be more open-minded as doctors. So stories like yours are incredible because you have the personal experience of trying it yourself, trying it with a family member, seeing the life-changing potential. And then you go forth and you can apply it to your hundreds, if not thousands of patients that you see. So how did you then make the transition to treating your patients who come to you for a different problem, right? They're not coming to you for diabetes. They're coming to you for cataracts and for eye problems. So how did you make that transition then to try and help them understand the importance of nutrition and lifestyle and carbohydrates and so forth?
yes, Brett. First of all, I have to say that, yeah, I don't blame this particular doctor or any other doctor, because I was one of them. When I was in training, I used to look up at all my teachers, and I thought that they were doing a great job, and I learned from them. And I think it's just the system. It's what you learn, but it's important to raise your voice and to see that if there's something that it's not working, look for something else. So I I want to tell you one story. A lot of patients, when I started when I finished my residency and I started seeing patients, a lot of them would complain that when they started insulin, that their eyesight was even worse. And they were telling me about they were thinking about not taking the insulin anymore. And I would tell them, no, 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 don't do that. The insulin is helping you, so don't stop it. You're gonna hurt yourself. But right now, with the knowledge I have right now, I understand, and now I believe them. And I think it's exactly because the insulin, the only thing that it's doing, it's pushing the glucose into the cells, including the retina and all the cells in the body. So it's logical that it's getting worse, that the vision is getting worse. So I now believe them, and I try to take them off insulin, and I encourage them and tell them that it's possible.
Yeah. And they must look at you a little crazy saying, "Well, what's an eye doctor doing telling me about my nutrition, especially when my regular doctor is not teaching me about nutrition?" So do you get some resistance and some people thinking like, "Oh, she doesn't know what she's talking about," or people seem to be more accepting of nutritional advice from you, especially low carb nutritional advice?
Yeah, well, I'm lucky enough to have some examples. For example, when I tell patients about my dad, I don't try to push the low carb diet, but I always tell the story, for example, of my dad or my husband, who also he had hypertriglyceridemia. He was like in the high 700s. Only with diet, in 1 month, he went from 700 to 150
Wow.
milligrams per deciliter. So I try to tell these stories to my patients, so that they trust me. They don't think, oh, this is just a fat diet or some experiment that the doctor is trying on me. This is something that I tell them the story that my dad refers the diabetes, or my husband, so they trust me even more, because I try to explain them that way. And so they just say, oh, okay, I will give it a try. And I try to Well, I direct them to my social media or my webpage, because sometimes I don't have like a lot of time in that at that moment to explain them. And when they do their own research, they come back and ask me for to help them with the diet and the well and the all the other well the sleep, and I try to incorporate a lot of other stuff other than diet in
That's
lifestyle.
great. Yeah, definitely a multifaceted ophthalmologist looking at far more than just vision in the eyes. That's wonderful. Well, it certainly seems like you've got a nice sort of protocol figured out. I mean, just by who you are and clearly caring for your patients and being interested and wanting to help them, plus with your own personal stories and your family stories and your patient stories, it's you can really connect with them and having another avenue to send them to with videos. But it seems like you probably have another hurdle. So being in Mexico City, I mean, let's be honest, the Mexican culture is very involved with food and specifically carbohydrate rich food with beans and rice and tortillas and chips and that's a hurdle in and of itself. So tell us a little bit about what you encounter from that standpoint and what some of your strategies are to help people kind of get over that.
Yeah, well, yeah, in Mexico, food is delicious. And I think since you are a little kid, your mom and your grandma, they're all showing you or demonstrating their love with food. So people in here are used to use food as a comfort. So it's very hard, and people love their beans and they love their tortillas, and so sometimes they are reluctant to change. But I that's where I use a lot that of the Diet Doctor website to show them that they can switch some very easy like swap things to make them delicious. And for example, for tortillas, I we have here many people don't know them, but we have nopal tortillas. That's a cactus that it's very prevalent here in Mexico, and it's really high in fiber and very low in carbs, in net carbs. So we usually do that little switch to tortilla to nopal tortillas. And for example, or if when they want to eat tacos, that it's everyone eats tacos in here. I just ask them to wrap them in lettuce instead of tortilla, or cheese, like hardened cheese, and so it's not so hard for them. Also, for example, for hamburgers, I also ask them to have them in between two lettuce wraps. So if there are small changes that they can do to improve. Other things that I do is, for example, instead of rice, I teach them how to make cauliflower rice. So it tastes exactly the same and or very similar. So
Mhm.
when they notice that they can eat almost as if as before, just with little tweaks, then they get motivated because they see results and they start making these changes. Another tool that I use a lot is the continuous glucose monitor. For example, a couple of years ago, when I came back from Toronto, there was none in Mexico, so I tried to bring here as much as I could, and that was, for example, for my dad, it was a very helpful tool because he didn't want to leave rice. For example, I always the first step always in the treatment or in the protocol is to switch from processed foods to natural foods. So my dad was, oh, but beans are natural, they are not processed, so I don't think they are bad for me. But when he got the continuous glucose monitor, he starting to see how his blood glucose would spike and then go down even at lower levels than at the beginning. So when you have a visual clue of what's happening with each type of food, then they get it and they start changing, and that's when they get the importance of the carbs and everything else.
Yeah, well, I'm thrilled to hear that you're using glucose monitors, CGMs. We had a whole episode of the podcast with Dr. Casey Means talking about CGMs, and they're so valuable for patient learning experience. both, how their actions and what they're eating, how it affects their blood sugar, and that immediate feedback is so important. So yeah, glad to hear that you're doing that. And right, I mean, substitutes are so important, because at Diet Doctor we have these tortillas you can make with eggs and psyllium husk, and so that you don't have to give up tortillas. And if you're using cauliflower rice, you can still season it with similar seasonings to get a similar taste. But I'm sure there's sort of a resistance at first, or a hesitancy, especially like in families that might have multi generations living together, because older generations might have zero interest in making any changes, and younger generations too. If the taste is different, they might not be interested. So it's someone making a change for themselves is one thing. Someone making a change that involves other members of the family can also be challenging. Is that something you see in Mexico, with sort of maybe multi-generational living situations and difficulty or barriers from that standpoint?
Well, I usually have the mom or the spouse of the patients coming to the consultation, because they are the ones who cook. So if they understand how the diet, what change they have to do, then the whole family would do the changes. For example, well, the most extraordinary case that I have up until now, it's been a patient who was born with a genetic condition called Prader-Willi syndrome. So she was a 39-year-old female patient. So he came here with obesity since childhood, and she had short stature and small feet, small hands. And these patients usually they have obesity since childhood, and they are always hungry. So it has been until recently that they have discovered that they have leptin resistance. They have very high levels of leptin. So for them, it's sad, but they are always hungry. So this patient, he came with her mom. And so I explained to her mom, and we made a protocol for her. She started eating only 3 times a day, trying to avoid snacks, only natural foods, nothing processed. And it was a slow progress with ups and downs. But finally, after like 6 months, she could lost about 25 kilos. That's about 50 pounds. And also, she could leave a lot of the medications she was taking. For example, she was in 3 different types of insulin. She was taking oral hypoglycemic agents. She was taking even SSRI for anxiety and agitation. So we could start taping her off, and now she's doing great. And I think she's an example, because if someone with those levels of leptin resistance and being always hungry could improve that much, I think anyone can do it. Also, her mom told me that how it has changed her life, and how she's happier now than ever before. So I think involving the whole family, and especially the moms, can be really helpful.
Yeah, that's a great example of something that's so important, and people don't have to and shouldn't do it alone, but engaging the entire family as assistants and educating them on the importance of the change is wonderful. So that's great. Now that you've been doing this for years now, helping people change their diet and promoting low carb, have you started to see patients come back so you can re-examine their eyes and see any changes, either any improvements or certainly lack of progression? So I guess my question is twofold. Have you seen that? And then is there any studies or evidence or science to support that nutritional interventions can halt or reverse the progression of diabetic retinopathy?
There's well, in the ophthalmologic medical literature, that it's clear that the number one prognosis factor to developing or progressing the diabetic retinopathy is the control of their blood glucose levels. So with this intervention, we can see that people really stop. I usually operate on patients, but then I have them come back at least every 6 months. or earlier if it's their disease it's more advanced. But people notice that they see better, that they are not progressing, that they are losing weight. So I can definitely see, especially not progression, an improvement in their eyesight if their diabetic retinopathy is not in late stages. But yes, there's evidence, and I think low-carb diets and ketogenic diets and fasting, all of them have shown to help with the control of the glucose levels more than anything else.
Yeah. And there is, I have seen some research about um, ketogenic diets for glaucoma and for optic nerve disease. And, there's small studies, and I don't think a lot have been done. I tried to do a search and didn't come up with a whole lot. But I would hope that this is a field that's going to get more and more attention, because just like we're worried about vessels elsewhere in the body and metabolic health elsewhere in the body, it affects the eyes as well. And let's face it, I mean, there aren't a lot of great treatments to reverse it, to reverse that problem, especially if it's late on, like you said. So if something as simple as nutrition can make the difference, that's something I'd like to know about, and certainly hope more people are studying it. Um, have you started to see any trends in the ophthalmology community, like in conferences or in just other colleagues talking about it, that people are starting to get more interested in lifestyle interventions for eye disease?
Not very much, Brett, at least
No.
not here in Mexico. Yeah, unfortunately, they're more focused on new anti-angiogenic drugs or new types of laser to photocoagulate the retina, but not so much in this intervention, in like lifestyle interventions. But I think, well, we're spreading the word. So I hope that and especially if we can tell the patients, then their patients tell their primary care doctors, and I think slowly we're gonna spread the word. And for me, it's very important that patients know that this is not a chronic or a condition or a life. Well, it's chronic, but it's not a life sentence. That they can reverse it. And but most patients think they can't, so they are depressed and they don't even take good care of themselves because they don't know how to. It's just a matter of telling them and showing them the way that they can do something about it besides the medication, and that's when they open their eyes and they start doing small changes. But yeah, in the ophthalmology world, not yet. We're
Yeah.
starting, and I think more people will get in this boat.
Yeah, I hope so. I hope so. Well, I think there are a number of take-home messages from this podcast, and one of them is at, like you started with saying, get your eyes checked. If you have type 2 diabetes, get your eyes checked, because you may not know that you have retinopathy unless someone takes a look and takes a detailed look. Um, but also, even before you have type 2 diabetes, still important to get your eyes checked, because like you said, you've been able to pick it up on people who haven't even had a diagnosis. And the same for high blood pressure. High blood pressure causes other problems that you can see in the back of the eye. So I think that was a great take-home message. What other messages or thoughts do you want to leave our listeners with today?
Well, I would like them to be their own advocates, to advocate from their health, because here in Mexico, it's very prevalent that people trust the doctors at 100%, and they want like a magic pill. They
Mm.
want, for example, they get the diagnosis or even diabetic retinopathy, and they think that with laser or with the intravitreal injections they are going to get better, but they don't want to do any changes. So I want them to know that I mean, it's good to trust their doctors, but I want them to do their own research, to know that this is reversible, that they can ask their doctors to what other options do they have. And I think it's very important for them to know that there are other options, that they can do something about it and not just take the medications or do as exactly as the doctor said.
Yeah, that's a great take home message, that we really do have to be our own advocates, our own best advocates as patients. And fortunately now with the internet, we can find other sources of information. Now, hopefully they're credible sources of information, but there are other ways out there to educate yourself and hopefully help educate your doctor. And as you were explaining that, also, the obvious point that you can treat the diabetic retinopathy with lasers, with injections, but that does nothing for your kidneys, for your heart, for your peripheral vascular disease, for your whole, metabolic system in your whole body. So it's a local problem to a systemic issue. I'm sorry, local solution to a systemic problem and a systemic issue. So advocating for yourself to get treatment that's going to help your entire body, not just the one local problem, is definitely a great take-home message as well. So, well, thank you so much for taking the time to join me. I really appreciate your information. And you mentioned a YouTube channel and some other sources that you have. So where can you direct people to go to kind of learn more about you?
Sure, but our webpage is inedia.mx, and we are also in Inedia in Facebook and in Instagram, so they can look me up. Right now, for ophthalmology, since COVID-19, I'm only doing consultations for ophthalmology. I can do it online, but for metabolic health, I'm doing it online. So people can reach me there, and if they want more information, they can look in social media.
Great. Now spell that website for us, just so everybody can.
It's INEDIA.
Very good. All right. Well,
.mx.
.mx. Great. Well, I'm sure that's a wonderful resource that we can put a link down in the description below of the podcast. So wonderful. Well, thank you very much, and I wish you luck, and I look forward to seeing a lot more from you in the future with all your advocacy. So thank you.
Thank you, and excuse my English, that is a little rusty.
I know.